I'm Lisa Towers, Director of Marketing for Lumina Health Partners. I'm speaking with Jim Grana, Chief Analytics Officer for Rush Health, and Dan Marino, Managing Partner for Lumina Health Partners. Thanks for joining us today.
It's great to be here.
Great to be here, Lisa. Thanks.
So you'll be presenting Creating an Analytics Ecosystem to Drive Optimal Performance in a Risk-Based World on Tuesday, June 25th from 1:30 to 2:30 p.m. at HFMA's annual conference in Orlando. And as part of that discussion, we wanted to give our audience a little bit of insight into what we'll be talking about. And as organizations move into value-based care, they face the challenge of creating an analytics ecosystem that is critical to assuming risk, quantifying clinical outcomes, controlling costs, and managing the care of defined populations. So let's explore this a little bit further. If someone's new to an ACO, where should an organization start?
Well, I'll start out, and then Jim, I'll let you jump in. You know, a lot of times as physicians are managing or treating patients, they do a really good job of taking care of the patients who present to their office. A lot of times what they don't focus on is the patients who don't necessarily come to their office, or when the patients leave the office, really continuing the care of that patient. So when managing the ACOs, it's important to understand what are the drivers of the risk, those patients who really need the most care, the most complex patients. And then as you're starting to identify those patients, starting to really put in place the right level of programs, interventions, and so forth. So you're really able to impact the quality and then impact a lot of the medical spend as well.
Yeah, and I agree with Dan 110%. You know, starting with an upside-only MSSP plan or ACO plan in general is generally a good idea, because that gives you an opportunity to train, to learn before you're absorbing any additional risk from a financial perspective. When people ask me what should they do first, I say the very first thing that I would do is evaluate the network and identify those providers that you think would be contributors to your bottom line associated with the shared risk program. So evaluating providers, creating an appropriate network, getting leadership buy-in associated with that MSSP plan, educating that network, and then of course doing the analytics. When I talk to analytics, obviously all analytics starts with data, and I would do exactly those analyses that Dan had alluded to a moment ago in order to identify those patients who would benefit the most from outreach programs, and identifying those patients that are likely to be high cost, such that you could have an impact on that cost and lower the cost associated with them, such that you could gain from a shared risk arrangement rather than have to write checks.
And you touched on this a little bit in your answer, Jim, but where do organizations start to get insights out of their analytics to impact shared savings?
Well, there are a number of different places where somebody could get insights from their data, and I'll bifurcate my answer in two general areas. One area I would focus in on the providers, to better understand your provider network, to better understand those providers that are doing well, that have better access such that people can get care from, say, their PCP as opposed to a higher level of care like the ER. I'd start to evaluate the providers. The other side is evaluating the patients, identifying those patients that are most likely to have an acute exacerbation, end up in the hospital, the ER, those that are likely to be very high cost and might need more intensive care management, and doing appropriate predictive modeling using the different artificial intelligence techniques and machine learning techniques, such that we can identify those patients that would benefit the most. But you're not just identifying the patient that would benefit the most, you're making sure that you're using very limited outreach resources on the patients that would benefit the most, and it really benefits the MSSP plan or the ACO plan as well as benefiting the patient. So it's kind of a win-win.
Yeah, I couldn't agree more. Jim, you're absolutely right. And especially as you start to think about the predictive modeling, where a lot of organizations do fall short is translating what's occurring with the way that they treat patients to what it means in terms of their opportunities to achieve some shared savings, or at least be able to mitigate their risk. So as you start to model the populations, identify who those high drivers of costs are, you can start to put in place those interventions, which then, based on some of your modeling, you can start to anticipate those impacts. As you start to put in place those interventions, that's what really allows your providers to understand how they truly could influence the care, integrate that within their workflows, and so on and so forth. Really make a difference with their performance of their ACO.
Great.
And what have you learned when you've aggregated data?
Well, certainly aggregating the data is a critical first step to the analytical dimensions associated with an ACO. And what I'm referring to here is taking all the data from all the providers that a patient sees, not just the data from your own provider network, because in a PPO-based, say, ACO, where people have choice and they can go to any provider that they want to, you're only going to get part of the picture when you only look at your own data. What you want to do is have access to data for all of the providers that that particular patient or group of patients sees. So you want to aggregate all the claims data. You want to get your hands on as much psychodemographic data that you can get your hands on. You want to aggregate that as well. You want to get as much clinical data that you can. When I refer to clinical data, I'm talking about, say, the EHR data that you have, say Epic data, or whatever your EHR is. You can amass that data into one repository and hopefully standardize that even across payers, such that you can get adequate volume, such that you can generalize properly to a given provider. That's an important point, actually. Trying to aggregate the data across payers is very helpful. We found it to be very helpful here at Rush Health, such that we are not kind of shackled by the sample size with only, with one payer. We can take the data from multiple payers, aggregate the data, put it all together, and get a clearer picture of each of our providers' performance.
Yeah, just kind of building off of Jim's comments, the aggregation of the data is so critical to the success. Many organizations have a lot of elements of data that is coming from their EHR. They're starting to now really get a lot of payer claims data. Some may have social determinant data. So really they're quite data rich, but really information poor. They've not done a good job of aggregating the data in such a way that it provides real actionable insights. And one of the things that I'm looking forward to as part of HFMA is really helping folks understand how they can build this high-performing ecosystem of data, driving true actionable analytics. And it really comes down to understanding where to start, having the methodology in place to aggregate those right sourcing of data so you can create some really strong insights that drive overall performance.
That's a great segue to our next question. Which data has been key in succeeding in value-based care?
The data that we get from the payers themselves is certainly central to, and that's the first step in the process as far as the financial aspect of these shared risk arrangements. Why? Well, because one, those data include in and out of network care, and two, your shared savings will be calculated or lost as a function of those data. So those data are going to be very important from a financial perspective, very important because it includes your in and out of network. So the very first step that I would take is to address the claims data that you get from the payer. And the payer, at least universally in our case, all the payers that we're working with shared risk arrangements, they give us all of the data. Sometimes they have pharmacy coverage. Of course, patients have pharmacy coverage. Sometimes they don't. And most typically, if the patients do have pharmacy coverage through the carrier, we get those data from the carrier as well. So that's the very first step. And as I had alluded to earlier, the second step is to integrate the clinical EMR data along with the claims data. And then the third step would be to get a hold of psychodemographic data, social determinants of care type data that could include zip code oriented information or marketing data that you can get from third parties to give you a better indication as to what the socioeconomic status of somebody is. And certainly survey data, if you can get a hold of survey data associated with the individuals that you have on your platform. That can be very helpful. You can start to identify barriers to receiving the appropriate care. And when you're in Chicago, as an example, you will come across a number of people who have transportation issues or have other barriers to receiving care, and that helps us to make sure that we provide them with the services that they need to optimize their experience and be as efficient as we possibly can with the delivery of care for those patients.
Yeah, I guess I would add one other point. When you're thinking about the ACO, you're really solving two main problems. One, you really need to know for your providers what's occurring with that population and what really comes out of that claims data. It tells you, what the medical spend is, where the services are occurring, are they in network, out of network. So there's the what really does influence a lot of the costs and the medical spend and so forth. But if you're really going to be successful with the ACO, just understanding what is occurring isn't enough. You have to understand why it's occurring. And the why occurs with the clinical data. And Jim is absolutely right. To integrate the clinical data with the claims data helps you really understand, for instance, what's occurring with your population from a medical sense standpoint and where they may be getting their care from. But it also then begins to understand through the why and integrating the clinical data, are these patients, have multiple comorbidities? Are they considered high risk? Do they have an A1C level that's, over 8, which puts them at a very high risk, complex patient category? So really the integration of that becomes critical. And then you layer on top of it other sourcing of data, such as social determinants, the experience data that Jim had mentioned. So as you're starting to build that ecosystem, all of those elements really provide what we would call this 360-degree view of your insights to really drive a lot of strong output and obviously influence the care that you're delivering to your patients.
And if I can build on something, I think Dan raised a particularly important point, and that is once you get all of these data together, you can look at each patient and understand what their comorbidities are and kind of get a full picture of each patient. And then you can also look at each provider and figure out what the burden of illness is associated with the panel that's attributed to any given provider. Those kinds of activities that Dan was talking about are particularly critical because it's not just, is this patient at risk of having an acute exacerbation, as Dan had said. It's also, why are they at risk of having an acute exacerbation? What are those specific issues that they have, comorbidities, polypharmacy issues, gaps in care, whatever it might be. So you can kind of get a very thorough indication as to what each patient is contending with when you aggregate the data and analyze it appropriately and create the appropriate scripts such that you could fire off warnings to providers such that they can do the appropriate outreach.
Great. And what kind of internal talent is required when you're working on a project like this?
First of all, you need to have a very robust IT group that's capable of bringing the data that is made available to you together, standardizing those data such that they can be analyzed. In a very broad sense, I'll just refer to this as IT resources, the specific skill sets that they have. There are many choices in terms of what platform you put the data on and how you standardize those data, but I'll consider that an IT function that is curating the data and providing access to those data for the analytical team. The analytical team typically has to have both a number of different backgrounds. What I've seen work the best in the past is having people who have somewhat of a clinical background. They need not be clinicians themselves, but certainly understand ICD-9s, ICD-10s, I should say, CPT codes, NDC codes, GPI codes, all the different kinds of codes that are clinically oriented. But they also have to have a pretty good understanding of things like SQL, people who are well-trained in inferential statistics, predictive modeling, artificial intelligence, machine learning, people who are very good with SAS or R. Those are particularly strong statistical tools that I've seen people use very well in the past in this particular industry. And then people who can can get the data out. And when I say get the data out, I mean, I'm talking about mechanisms to deliver the information, whether it's through push mechanisms from a digital platform, or whether it's from more of a pull distribution mechanism on the intranet, or cloud-based delivery programs as well. Tableau is another very good tool for visualizing results, aggregating them, and getting those out to individuals who can actually use them. Another very important connection is to get the results into the workflow properly, such that we're not having separate systems to log onto. And whatever your EMR is, having the appropriate talent that could take the algorithms and output from the analytical team, from my team, and get those outputs incorporated into the workflow. It's critical to have somebody with those skills who can get it, say, into Epic or into another EMR.
Great. Well, thank you. I appreciate your insights today, and thanks for joining us. And again, Jim and Dan will be presenting Creating an Analytics Ecosystem to Drive Optimal Performance in a Risk-Based World on Tuesday, June 25th from 1:30 to 2:30 at HFMA's annual conference in Orlando. So if you'd like more information about that, you can go to hfma.org to learn more or register. Thanks again for joining us. Have a good afternoon.